Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, Dr. Pedro Cardoso, from the Hospital of Santa Maria, part of the University of Lisbon in Portugal. So Pedro is a great friend, a great CTO operator who has pioneered doing CTO and complex PCI in Portugal. Pedro, thanks so much for joining us today in the podcast.
So thank you, Manos. It's a great pleasure and a great honor as well to be part of your Sensei podcast, which I have been hearing. So thank you.
Thank you, Pedro. And maybe we can start from the earlier days of your life. So how did you end up going into cardiology? How did you decide to do intervention? What made you follow this route?
Well, I always want, since I was a kid, to be a doctor, to be a medical doctor. And then I had an uncle which I loved, who was a cardiologist. So I really always wanted to be a cardiologist since I got into the university. So it was a very old option. And then after being a cardiologist, I was really very interested in intervention because, being able to treat patients the way we do was always something very, very interesting for me. And so I decided when I was a fellow that I would like to do interventional cardiology. So it was since the beginning, really since the beginning.
Wonderful. And then how did you decide to go into the complex coronary work? It can be a little challenging. There are some risks, complications. What made you want to go into this area?
Well, really, it was the need to, because I used to work in a small hospital. Then I moved to this one. And we obviously, like in all other places, we had some complex cases. And namely regarding CTO, I felt that I was failing some cases, and the patients really needed to be treated. So it was. I really felt the need to improve my skills doing CTOs, and so at that time I met José Rumoroso, who was my first teacher, let's say, my first master. And so I made I think maybe 15 years ago or something like that, I made my first proctoring with him. And I really changed completely my way of working, new guidewires, a new philosophy, if we can say like that. And then I always kept on working with masters. Then I met, for example, James Pratt here in Portugal, in Oporto, and lately Camis Machaekis and Roberto Garbo. And so I used to share with them. And I keep on learning. I keep on learning. I think that we always learn. And I know I really got interested in the field. So I started going to the courses, to watch live cases. I think we learn a lot with live cases, and that's it. So
it's a lot
that's why I started.
So many people came over, you work with them, you get some treatment, but of course also you worked with yourself. And how did the hospital, how did your hospital approach this? Were they happy to do it? Was there some concern? Was there some difficulty getting the equipment? How easy or difficult was it to get the program started in your hospital?
Well, the main it was not difficult. We can have all the material, and yeah, I didn't have any difficulty regarding this. The main difficulty that we had is because we work in a very busy hospital, doing other procedures, namely other complexity, other complex cases, and also structural heart disease, namely TAVI. And so it's like we work in a busy cat lab, and it's the main difficulty that we have keeping doing the CTOs, but not with the hospitals, not with colleagues. Yeah, it was
Wonderful.
yeah.
And then did you build a team? Like, do you work with the same technicians and nurses when you do those cases, or it doesn't really matter?
Well, unfortunately, not because it's not easy because they have their own scheduling, so it's not easy. But I still try to do a little bit of this. So I work with one two technicians, preferably not always. It's not possible to do it always, but yes, I try to share the cases with them to bring them to also to the courses. Yes, we do our best, but it's not possible, in such a busy environment to do it always.
Wonderful. And then when it comes to when things take a long time or when complication happens, how were you able to get other people to help you? How do you approach the complications, and how discouraging could they be for the program and for the progress in the hospital?
Yes, I always try to stay on the safe side. I always prefer to be unsuccessful than to have a complication. And I must tell you that I don't have many complications because I always prefer to stop and to as I told you, to be on the safe side. But anyway, we have a good team regarding the situation. Always, we always try to keep calm. We are in a big hospitals. We call the the anesthesiologists. So we have a good environment regarding that. But I always think that we must prevent complications, and on the other side, if you have a complication, but you are treating patients with a good indication, well, we must accept them. We must accept it. But what I think is that we should not push too much. Really, we don't need to treat all the CTOs, and we must also keep in mind that we must weigh the risk benefit, and so this is very important. This is not a statement of mine, but someone used to tell that the only contraindication is the absence of indication, and we really have to be very
Careful about.
to know, yes, of the situation, because if we respect indications, we always accept better the complications that we can have.
Wonderful. And then, do you do the cases by yourself? Do you have any other colleagues or fellows you work with? How do you do your procedures?
Well, fortunately, I don't have other CTO operators in my cat lab, but I'm working on that. I'm training a young specialist, and I hope really that he will be the second operator, not only to share the cases with him, but also to be sure that I will have someone to follow me once I leave the cat lab. It's very important. I'm working on that, but unfortunately, I work not. The other doctors are not so dedicated because young people now they want they are very dedicated to structural. I think sometimes young people are so enthusiastic about structural that they forgot a little bit coronary heart disease. So, but now I have a young guy, and I really hope that he will follow the CTO program. I really hope that. Yes,
Wonderful.
and that's why I share. I continue to share the cases with my masters, as I told you, with Jose Romuroso and the other. Yeah.
And Pedro, what did you find the most difficult thing to learn in CTO PCI? Was there a technique? Was there a thinking? What was the most difficult thing for you and your team to implement into treating CTOs?
Well, really, I think that everything is difficult in CTOs, and sometimes you are going to do a complex CTO, and finally at the end it's not so difficult, and the opposite is true. Sometimes you have quite what seems to be a simple case, and then it turns to complex. So um, the my I think that well we have to obviously to know all the material, but the first of all you have to learn before, but you have also to do it on a regular basis, and then I think knowing sometimes understanding the anatomy, it's for me it's not easy to, for example, with very ambiguous proximal capsule. Sometimes it's not easy. We can try to use divers, but in some cases, even doing IVOs, it's not easy. So understanding the anatomy for me it's quite important, and it's a difficult thing. Then I trained in all the techniques. I must tell you that now I'm using more antegrade and then retrograde, sometimes ADR. But I think that we when you are more trained in one technique, you always prefer that technique. And I know that most people are not most people, but many people are preferring ADR because it's safer. But it depends on on your experience, and well, that's it. But I think that I don't know if there is one thing more difficult than, because everything is difficult in CTOs. Really, it's probably the most difficult work that you can do in interventional cardiology. I think so.
So, were you always interested in doing the difficult things, or this is an
Yes.
acquired taste? That's something that came later on.
Yes, no, I was always interested in doing difficult things, but I think we have to keep in mind that we do it for the patients, and because interventional cardiologists always want to do difficult things, and we must always think the benefits, because we must not forget that we are treating patients, and it's more important to do what is the best for the patient than doing difficult things. So I try to balance both things.
Wonderful. And then when it comes to teaching people, so as you say, you're training now one of your colleagues, you're training other people. What do you find? First of all, what do you find the most difficult thing to teach, and how do you select them?
Well, I think starting by the end, I think the most important thing it's the attitude. It's the because everyone can learn, but I think that the attitude with the colleagues, with the patients, it's very very important, and some humility as well. Then, of course, have more skilled people to understand. They will be more skilled, and so um, I think that it's important. But the main thing it's really the attitude. And then, to teach people, it's not easy. It's not easy. And even when I think about my masters, you can see that there are some people who can stay behind and teaching, but there are some other people where when you can learn with them, watching them working, but really they have some difficulty in even they are fantastic operators. It's sometimes it's difficult for them to stay behind and not to do it by themselves. And I understand this because for me it's also a little bit difficult. But I always try, for when I'm teaching, if even I have to have some help, just to quit when I've done something, and to try to give the wires back because it's very important to people. I think people learn mostly training and doing and feeling the difficulties that we feel. I think it's more important. It's the most, yeah.
And I could not agree more. You're right that the best way to learn is by doing, and sometimes you can do this in much faster and efficient way, but otherwise it'll be hard for them to learn. So it's always the balance. How much do you let them try and understand
Yeah,
this before it taking over? But
yeah,
it's again, I don't think it's a perfect balance, but it's good to the more they get, I guess, the better they progress. It's always a situation of balance. Now, when it comes to being in the cath lab, you've been there for many years, a lot of radiation, lead, and everything else. How concerned are you about radiation issues? Do you do anything specific for that, like the Rampart or the other systems? How concerned are you, and what do you do for radiation protection?
yes. I'm not using the red pad, but I would like to have it. I don't have it, but recently I asked if we could have the red pad because it's I think it's quite important. But obviously we are also concerned about radiation, and what we do is to protect ourselves to use low program radiations for CTOs. Uh, we always try to do star fluoring to to lessen the radiation that we use, so we don't film too much. Um, and not much more than this, but we usually keep we are able to use not so much radiation. And if I'm not having progressing and the radiation is already a little bit high, sometimes we stop and we prefer to do it in the second time. But we try to use the lowest radiation possible in all the cases and mainly in CTOs.
Wonderful. Now, are there any cases, good ones or bad ones, that really stuck with you that you learned a lot from, that might be useful for people to learn from as well?
Well, I don't know it specifically, but not really. I think I learned with all the cases, but I can't remember anyone specific where I learned more than in other cases. No.
Sure. And then how do you how do you keep yourself in good shape to do these procedures? Do you exercise? Do you do something to relax or get better? How do you keep yourself in a good shape?
Well, unfortunately, I don't keep my. Well, I'm not in a bad shape, but I really don't do much exercise. The only thing that I do is pilate because it keeps me out of pain in the back.
Okay.
But I used to play tennis, but I'm not very prone to sports. I had two times tennis elbow, and so I don't like swimming. I had problems with skiing, so really, I had to quit. Unfortunately, yes.
Now, how about your favorite books or favorite movies?
Well, I don't have favorite books. I like very much to read if and I don't have too much time to do it. I always used to read when I go in my summer holidays. But well, I can tell you regarding medical books, beside yours, you I remember probably in the university there was a wonderful book of physiology from Gitten. Probably you remember.
Yes, actually, the
Remember
same
it?
thing. Yes, yes, the Guyton.
Yes, it
Yeah, yeah,
was
yeah. It's a great book.
Guyton. Yes, it was a wonderful book. And I used to like to study this kind of physiology, those things that you can't understand, because really I think that nowadays we in cardiology we have to know a lot of trials and not a lot of things that's not logical. And I always prefer to learn the basics, and it Gatins was a very interesting book. And then well, I remember, for example, um, I remember a book that I read many years ago. um, I'd like to read it again, because from Ernest Hemingway, For Whom the Bell Toll. I don't know if you
Hmm.
know the book.
Yep, yeah,
It
absolutely.
was this kind of book that you are not able to stop. You want to keep on reading it, and well, I like very more recently. I read a very, it has nothing to do with the previous one, but I read an interesting book from Amor Tolls. Probably you know him. I don't know. A Gentleman in Moscow, and it's an interesting book to read it in the summer. So, well, beside other books, but those
Perfect.
I got in my memory.
Wonderful. And then, what excites you the most going forward in interventional cardiology? Are there some areas that super excite you, or even the complex area? What do you think are the things that are going to make a difference and improve things?
Well, I really don't know. I really don't know. Structural intervention is going very very fast, and it's wonderful to treat patients the way we treat the patients, like for example for aortic stenosis with TAVI. It's fantastic, and I think that also with mitral valve and the tricuspid valve, things will improve a lot, and it's very very interesting, because you are able to treat patients in a non-invasive way, and so it's very very good for patients. Um, Regarding the interventional cardiology, I think we made a lot of progress. We made a lot of progress. For example, dealing with calcium, which was a very. I used to say that my what I fear the most in interventional cardiology, it's low ejection fraction, and it's the and calcium. probably that's the things that I fear the most. And we made a lot of progress regarding this. Well, I don't know. I don't know in the future, but for sure we will have more tools, and it will be much easier and much better for the patient.
Wonderful. And then, Pedro, what are you most proud of, both personally and professionally?
Well, personally, to be an honest people, that's maybe the most important thing. Well, but I think that we have a very rewarding profession. We deal with what it's most important to people with health, and so we. I don't need that. I don't think that we must that we need any more motivation. I'm very motivated to treat patients. It's very pleasant when you are doing something good to the patients, and I feel proud, yes, of being useful to the patients. I have a good relationship with the patients, and yes, I think I can be uh, proud of it. We were talking about cases that we can remember, and it's not because I learn more with this case, but I remember one patient, 70 years old, he had a bypass surgery twice already, because he had the limb to the LED occluded, and well, with angina. The first time he had surgery he was like 40, 45 or something like that. And well, he has the LED occluded. I tried to open it, uh, but it was very difficult because it was attempting. There was attempting, with the graft. I went to septal, but I couldn't do it. And at this time, I asked the help of Rumoroso, and after 3 hours, when he was almost giving up, he was successful, and the patient got much better. And it's very very grateful to treat this kind of patients. He's completely asymptomatic right now. It's wonderful. I think we have a wonderful profession.
Wonderful. Now, what are your plans for the future? Do you plan to retire? You plan to stay working forever? What are your plans?
No, I hope that I will not be working forever. Someone also said that we must leave the patients before they leave us. You know. So
That's
I think there's a time to quit. But well, I don't think to quit in the next years. But I would like to retire when I still will have health to profit, from being retired. So I don't know. For sure, I will keep working at least the next 10 years. We will see. Uh, we will see. But I don't have any plan right now.
perfect. And I think, for many people, we're discussing with some of the other heavy operators, many interventionalists who do complex NCTO, even though they retire, they still remain involved. They do proctoring, they do other things as well. So
Yes,
it
yes,
becomes,
yes,
I think, it's something that you feel strongly about. You maybe want to continue it for later on.
yes. I hope so. Mm.
And now, Pedro, you've done a wonderful program, treated so many patients. If you have to give some advice to younger interventionalists, early career, or fellows who are interested in following the same pathway and becoming CTO and complex operators, what are the key points you think would help them to be successful in that quest?
Well, first of all, to read a lot. nowadays we got wonderful books, and I'm not talking about yours. It's a very good book because a lot of technique and we learn a lot. But for example, James Pratt, which I also met, as I told you, in Portugal, has wonderful books about CTO. It's very important. We learn a lot with reading these books. Then to do obviously some cases with proctoring because it's very important. To do it on a regular basis, to try to do it on a regular basis as much as we can, and also to obviously to go to the courses because we always learn something when we go to a meeting with live cases and with all the people teaching us. We always learn something. So it's I think those are the main things that are important to be a good operator in the future.
Wonderful. Now, completely agree with you. These are all very important. What is your opinion about coronary CT, doing the computed tomography scans? Do you find them useful? Do you use them at all for your complex cases? And what is your thoughts for them and for the future?
I think that in some situations can be important. I'm not using to. Well, I used them once or twice, but not really on a regular basis. But I think that sometimes yes, because we can mainly to see the amount of calcium to see if there's any way to go. But I'm not used to use coronary CT on a regular basis.
Sure. And I guess that's a developing thing. I think there are now more, more scanners coming, and there's the heart flow, other things that can help with interpretation. So maybe we'll see more down the line. But again, Pedro, I really appreciate it. It was wonderful talking to you and learning from you. And I think that would help a lot of people earlier on follow your footsteps and become great operators. So thank you so much.
Thank you, Manu. Thank you for inviting me. It was a great pleasure, and thank you. We'll meet. Probably we will be in New York in 2 days.
Absolutely. Okay. Thanks again, Pedro, so much, and we'll see you soon.
Thank you. Thank you.
Thank you for listening to the Sensei podcast.